Name of- So this is a clinical picture of a neonate with the Hirschsprung's disease. You can see a tense, shiny abdomen, and you can see the visible loops also seen on a plain on the abdomen wall. So diagnosis can be clinical or plain abdominal X-rays are to be done. Then the diagnostic modalities of more significance are barium animas. Then confirmatory investigation is rectal biopsy or anorectal manometry. So on a plain abdominal X-ray or in a contrast anima, you will see dilated bowel loops. Then there is a collapsed terminal end of the bowel. Then proximal bowels are massively dilated. See this plain X-ray abdomen. There is a dilated abdominal cavity, usually distended abdominal cavity with dilated loops. And there is nothing, there is hardly any gas in the pelvis. So this is a barium enema. You can see three different zones. That is the spastic lower zone. Then there is a funnel-shaped middle zone. And there is markedly dilated proximal colon, which is a normal colon. Because the normal colon will get dilated. But the affected colon will never get dilated because it is disease part. This is another classical picture showing there is a funnel shaped area, there are dilated segment, then there is a transition zone where there are hardly any or few ganglion cells, and then there is a collapse area. This is another barium anema, same picture. So barium enema is it is less sensitive for detecting short and ultra short segment Hirschsprung disease, total colonic ganglionosis, and disease of the newborn. Many newborns they do not show any definitive transition zone, but only delayed evacuation of contrast. So you have to take a 24-hour film after doing a contrast study. Then rectal biopsy is the mainstay for the diagnosis. Either you can do a submucosal suction biopsy, that is the you to take in your biopsy segment of business submucosal plexus, or it could be a full thickness rectal biopsy where you have to see for the orbex mesenteric plexus. Then acetylcholine staining, there will be increased staining of neurofibers. So you have hypertrophic nerve bundles and absence of ganglion cells. Manometry may sometimes is required. There is a absent rectoanal inhibitory reflex, and there is lack of internal and anal sphincter relaxation response to rectal stretching. So if you do a rectal stretching, there will be a reflex relaxation of the internal anal sphincter so that the child can pass fecal matter. But this is absent in cases of Hirschsprung disease. Management includes definitive repair, that is transanal endorectal pull-through operations, which is done in a prone jackknife position. The most commonly used is a transanal endorectal mucosal excision, that is the swab-based procedures. A transanal approach is usually sufficient, but abdominal incision is sometimes needed for mobilization of long segment Hirschsprung disease or in older children. Nowadays, laparoscopic assisted transanal pull-through is used, and laparoscopy is used for mobilizing the bowel. So you can see correctly you can mobilize such a significant or long length of colon. Operative complications may include constipation, or there is could be stricture formation, there could be leakage at the anastomotic site, there are chances of post-operative enterocolitis, there are chances of anal incontinence. Now we deal with the entity that is called as Hirschsprung enterocolitis. This is a medical emergency that requires hospital admission and observation. You have to keep the child nil orally, you have to start IV fluids, IV antibiotics, usually broad spectrum antibiotics and metronidazole. And you have to do frequent colonic irrigation. That is, you have to do a bowel wash. And surgery is indicated in cases of if there is failure to conserve the patient, there is evidence of bowel perforation, or in the form of there is a failure to respond to IV fluid, IV antibiotics, then you have to do a labeling colostomy or loop colostomy. The another important surgical pathology is Meckel's diverticulum. So Meckel's diverticulum is a abnormal diverticular opening that is situated in the terminal ileum 2 feet proximal to the IC region, or that is intercostal ileocecal region. It is known as a disease of two because it is found in 2% of population. It's symptomatic only in 2% of the affected people, and majority of symptomatic cases are more than 2 years of old. It is seen at the 2 feet from ileocecal wall. It is approximately 2 inches in length and contains two types of active tissue, that is gastric or pancreatic. Presentation is usually a painless GI bleed, which is the commonest presentation seen in 50% of cases. Then bowel obstruction in 30% cases, and diverticulitis due to inflammation is seen in 20% of the cases. GI bleed. Most common cause of GI of bleeding in children is mucus diverticulum. It is usually painless, effortless, massive, and usually self-resolving. It is due to mucosal ulceration from acid secretion due to presence of ectopic, gastric, or pancreatic mucosa. Sometimes the child presents with bowel obstruction due to either intussusception, where diverticulum is acting as a lead point, or there is are mesodiverticular bands, which connects the diverticulum to the mesentery, and kinking of the intestine or internal herniation occurs. See, mucus diverticulum. So this is an intraoperative photograph of a 4-year-old child who presented with intestinal obstruction. On exploratory laparotomy, there was a mucus diverticulum which is causing a band obstruction. So the band was lies, diverticulectomy was done, and the patient was fine post-operatively. Mucus diverticulitis. Symptoms, they simulate acute appendicitis, result of interluminal obstruction, bacterial invagination, and progressive inflammation. Ectopic gastric mucosa predisposes to mucus diverticulitis. 30% incidence of perforation is seen, and there is high risk of peritonitis. Treatment in symptomatic mucus, they require either wedge resection with the transverse repair of the intestinal wall, or resection of the adjacent segment of the intestine, that is the ileum, with end-to-end anastomosis. Sometimes you find a mucus diverticulum during operation for another cause, that is incidentally found mucus diverticulum. If wall is healthy, if the base is broad and there is a short length, then leave it alone. If it is narrow base, long, and you can feel something thick inside, that is a thickened mucosa, then you have to do excision. Now, anorectal malformation. This is a very important topic because in an NICU you may get many admissions of anorectal malformations. Synonyms includes imperforated anus or anorectal malformations or anorectal anomalies. Frequency. Anorectal malformations occur in approximately 1 in 5,000 live births. One of the most frequently encountered digestive tract anomaly in pediatric age group. Frequency is slightly higher in males compared to females. Associated anomalies includes urogenital, another GI anomalies, or cardiovascular or vertebral anomalies. The same that we have seen in teofistula, that is vectoral anomalies. Then the reason is arrest of caudal descent of urorectal septum towards the cloacal membrane during the 4th week and ending by the 8th week of gestation. The important landmarks during that you have to memorize for diagnosing the type of anorectal anomalies are PC line, that is pubococcygeal line, and the I line, that is the ischial line. PC line is centered from the pubic bone to the last ossified piece of sacrum, and I line is a line parallel to the PC line, which is placed at the comma shape ischium. Now you divide anorectal malformations to high variety, low variety, and there is another category which is intermediate variety. Clinical findings includes findings are associated with high malformations are of flat perineum as evidenced by the lack of a midline gluteal fold. Then there is a absence of any anal dimple that indicates that the patient has poor muscles in the perineum. Perineal signs found in patients with low malformations include there is a presence of meconium at the perineum or bucket handle malformation and sometimes an anal membrane. This is invertogram, which we used to get do previously. You have to place a radiopaque sheet, coin or some object radiopaque at the anal dipper and then do a invertogram, which is we have to wait ideally for 16 hours minimum so that the gas can reach the lowermost point. You can see the flat perineum. There is no anal dimple seen. In a female child, there you can see a flat perineum. There are no openings seen. This is a perineal fistula. You can see a fistula's opening where you can find a speck of meconium. In case of bucket handle malformation, you can see a handle in the form of a skin ledge covering the anal opening. So this is a schematic representation of an imperforated anus with rectovesical fistula. This is a high variety anorectal malformation where there is a communication of the rectum into the base of the bladder. This is another, there is a communication with the rectoprostatic fistula area. The rectum has a abnormal communication with the prostatic area. Associated malformations include the following associated malformations can occur separately or as a vectoral association. They are esophageal atresia, duodenal atresia, ventricular or retroseptal defects, tetralogy of Fallot's, or Ashwin disease. Definitely, the treatment will be surgical, colostomy, and with or without primary colostomy, you can do a definitive repair also primarily. So this is a picture of divided loop colostomy. Your proximal loop placed laterally and the mucous fistula done medially. Definitive repairs include types of repair are anoplasty, which is done in rectoperineal fistulas, or there is a covered anus, or there is buccal handle malformation. And for high, intermediate, and high variety, you have to do a posterior sagittal anorectoplasty, that is called as PSRP, which is done in a from a posterior sagittal approach. Now, another entity is a very interesting scenario were intestinal malrotations. These are a group of congenital anomalies. They are resulting from an abnormal internal rotation and fixation of the small and large bowel. Embryologically, during 6 to 8 weeks, there is herniation of the midgut into the umbilical cord with the 180-degree counterclockwise rotation along the axis of superior mesenteric artery. So, superior mesenteric artery is the handle across which there is a counterclockwise rotation of the foregut that to the extent of 180 degree. By 10th week, these intestine, herniated intestine, they return to the abdominal cavity with a final 90 degree of rotation to complete a total 270 degree of counterclockwise rotation. And the pivot is superior mesenteric artery. Pathology includes there is non-rotation or incomplete rotation, resulting in abnormal positioning of the proximal small bowel and the cecum. Duodenal compression by abnormal peritoneal bands, which are called lead bands. There is high incomplete extrinsic bowel obstruction. Then midgut volvulus. There is torsion of the narrow mesenteric pedicle, producing an acute closed loop intestinal obstruction and vascular strangulation. Proximal jejunum fused to the ascending colon by anomalous peritoneal attachments. So these are a clinical as well as schematic representation of malrotation. These bands they are called as lead bands with the recurrent volvulus. Now in this picture you can see the bowel has already undergone gangrene. Clinical manifestations include the newborn will present with emesis. The vomiters will be bilious, then intermittent, usually occurs at 3 to 5 days after the birth, or sometimes they are asymptomatic. Abdominal distension, which is confined in epigastrium or diffused to the full abdomen in bowel necrosis. So, if there is an onset of abdominal distension in the case of malrotation, it is an alarming sign. Stool, normal meconium or bloody stool with volvulus and necrosis. Children and infant present with, they are usually asymptomatic since birth, but intermittent or sudden onset of intestinal obstruction occurs later on. Regarding the diagnosis, plain X-ray will tell you or will show you double bubble sign, although it is also seen with duodenal atresia, but it is also seen in the case of malrotation, because there is hardly any gas which is going distally. There are peritoneal bands or lat bands. Barium will follow through has to be done. This shows incomplete duodenal obstruction. There is ligament of twist not to the left of the midline. It is situated on the right of the midline, and abnormal positioning of the proximal jejunal loops to the right of the midline. So ligament of twist is on the right side, and abnormal most of the jejunal loops will be on the right side. Barium enema, cecum in the upper or the left abdomen. Treatment principles include, in cases of asymptomatic malrotations, most recommend surgical treatment. Some believe operation only necessary in young children only. In high intestinal obstruction, operate on promptly, but not necessarily emergently. Vulvas with sign of bowel necrosis, you have to operate immediately. Let's procedure or let's operation. This steps includes, usually we do a laparotomy through a right upper transverse supraumbilical incision. It includes untwisting of the volvulus. Volvulus is always clockwise, so small bowel must be rotated in a counterclockwise fashion. Division of flat bands, broadening of the base of the mesentery, then redistribution of small bowel to the right and the colon to the left of the abdominal cavity. That is the positioning of the colon. Colon has to be placed on the left side, and appendicectomy has to be done because we are placing the colon on the left side. So to avoid misdiagnosis of the appendicitis later on, we do appendicectomy. These 5 steps they complete. Let's procedure. So these are the schematic representation of LATS procedure. You are dividing the lead bands, then you are causing widening of the mesentery. You can see the fan has been opened, the mesentery has been widened, so that there is no chance of recurrent volvulus. Thank you.